Welcome to Sketchy. We take all the super complex stuff you need to learn and turn them into memorable visual stories packed full of everything you need to know on test day. Click the link in the corner or description to try for free for 7 days. Now let's get to it. And the Shock Force are back. Quickest sequel turnaround ever. Get ready for an epic battle on the streets of the big city. This sketch, and the next one in the series on shock, will focus on the deep dives into each of the 4 major types of shock. As you might remember from part 1, these are hypovolemic, distributive, cardiogenic, and obstructive. In this sketch, we'll cover hypovolemic and distributive shock. Check out part 3 of this series for an in-depth discussion of cardiogenic and obstructive shock. While each type of shock has its unique features, which we'll get to in detail in these 2 sketches, they also have many characteristics in common. These include tachycardia, tachypnea, altered mental status, and oliguria, in addition to hypotension, of course. We won't rehash these features common to all types of shock any further. Check out part 1 of this series, if you haven't already, to learn all about the presentation and initial management of undifferentiated shock. With that bit of background out of the way, let's get this party started with hypovolemic shock. Remember Aegir, the Norse water god? I mean, who could forget this guy? He represents hypovolemic shock, which results from decreased intravascular volume, hence his critically low cracked water tank, which in turn leads to decreased cardiac output and hypotension. Hypovolemic shock can be divided into 2 groups, hemorrhagic and non-hemorrhagic. Whoa, check it out. Looks like Aegir's winning his battle with our first supervillain, Bloodpool. Whenever you think of hemorrhagic shock, think of Bloodpool, our favorite supervillain jokester. As its name suggests, hemorrhagic shock results from, well, hemorrhage. It takes quite a bit of blood loss for hypotension and shock to develop. So think about hemorrhagic shock in cases of trauma, GI bleeding, aortic dissection, postpartum hemorrhage, or ruptured ectopic pregnancy. Non-hemorrhagic hypovolemic shock, on the other hand, is represented by our next supervillain, Secretion Man. Non-hemorrhagic hypovolemic shock is caused by severe intravascular volume loss, which leads to decreased cardiac output, hypotension, and ultimately, shock. The most common pathway by which non-hemorrhagic hypovolemic shock occurs is through excessive fluid losses, which can include severe diarrhea, represented by the brown stuff coming out of his jetpack, excessive diuresis, by the yellow jetpack exhaust on his other side, profuse vomiting, by his acid mouth secretions, severe dehydration from heat stroke, by those drops of sweat off his brow, or insensible fluid losses from severe burns, represented by those flames coming from that building. Intravascular volume loss doesn't have to mean fluids coming out of the body, however. Extreme third spacing of fluid out of the intravascular space and into the interstitial space, in conditions like crush injuries or severe pancreatitis, represented by Aegir's pancreas-shaped sponge hammer, can also result in non-hemorrhagic hypovolemic shock. Finally, rather than too much fluid leaving the body, hypovolemia can also be caused by not enough fluid coming in. Severe restriction of fluid intake, like if you're in the desert and had no access to water, can result in hypovolemia and non-hemorrhagic hypovolemic shock. That's why we've drawn in this broken empty water cistern. Let's talk about what historical clues you should look for to point you towards a diagnosis of hypovolemic shock. The presenting history in hypovolemic shock can be widely variable, depending on the underlying cause. As you can imagine, a person who was shot in the stomach is going to present very differently from the patient that's been having 20 profuse watery bowel movements a day. But they both may end up with hypovolemic shock. Clearly, the chief complaint will tell you a lot about what type of shock your patient might be facing. Here are some clues in the history you should also ask about. Trauma, represented by a recurring sketchy symbol, Bloodpool's arm cast, is definitely a big piece of history that you should ask every patient about. While you might be thinking, can't I just look for the clearly bleeding trauma patient? Many trauma patients may have internal bleeding that might be missed on physical exam. For instance, pelvic fractures can result in liters of blood loss into the pelvic cavity. Definitely enough for hemorrhagic shock to develop. While you're at it, ask about other common sources of major bleeding, most commonly GI bleeding, such as hematemesis, melena, or hematochezia. In addition to bleeding, you'll want to ask about common sources of fluid loss, such as the one we talked about earlier. Let's go back to Secretion Man. These questions should cover the most common sources of major fluid loss, such as diarrhea, vomiting, and prolonged heat exposure. One specific condition you should consider is diabetes. Undiagnosed or poorly controlled diabetes can cause significant hypovolemia from osmotic diuresis. At Sketchy, diabetes is represented by our recurring symbol, the Diasweeties candies. Sweeter than sweet indeed. Well put, random sign.